how many people? What did we think? How you guys? What for those? Jack was on yesterday. What did you did if you weren't already had some level of understanding of anterior midpoint stops, Jack, would you have thought that it was well documented yesterday? I think that's a good word.
Yes.
Would you?
Yeah. Absolutely.
One of my it's really important to me that these concepts don't come out as and oftentimes it's always associated with an agenda, as though you had something to gain, by it. That we have nothing to gain by people using anterior midpoint stops. It's that I have nothing to gain by that. I teach a course with Boyd, and I argued with him most of the time we've taught because he's spewing this crap that you don't have to. When you've got really good technology, why would you make stuff up about it that you don't have to? But it's when you're born that way, that's what you do. But I don't want like coming across that way. I don't like people thinking that there's some sort of agenda. I always find it when we talk about anterior midpoint stop appliances. I always find it interesting that we know that when it comes to doing splint therapy, good science on splint therapy, it's almost never done. It can't. It's really hard to do. You can't. First of all, there's no such thing as there's no way to manage a washout period. So there's no way to take the single patient, put him on an A splint, do a washout period, get him back to where he was, and then reinstitute the new, and then compare. And almost all of the science is done on some patients with some level of TMD, which of course is meaningless because we don't have a good diagnosis to begin with, and now we're going to compare apples to oranges no matter what so everybody accepts the fact that there is not really good science. Don made reference to the point that the Swedish studies are fascinating. Was it Swedish studies, Don? Was it was that done in Sweden? The studies with the compared
all Scandinavia, all three, Denmark, Norway, and Sweden. And what's interesting, but Sweden actually accuses Boyd of stealing the concept from a French author named Jean Monod, which is hilarious. Imagine Boyd reading French. So they just accused him of stealing the idea, and it just went downhill from there. And then who's the guy that he knew? I don't remember which country he was in, but a fellow who he probably was the largest purchaser of NTIs in Scandinavia, and he got in trouble with the government and the whole thing. It was just a mess. Yeah. And then those guys are the seat of academia in TMD.
So now they do this study.
He had the first index.
They do this study with flat plane appliances versus NTIs, and they came up with this kind of equal, no difference in patient outcomes. Well, what they did was they took the old style NTI, that first one, with a 4-inch discluding element on it, and slapped it in the upper arch, and they didn't want to adjust it because that would ruin the quality of the study, because that would be independent. They wanted control of it. So rather than following what we call therapeutic protocol, they put this in, and of course it was going to be problematic. And then they adjusted and balanced a flat plane. They were okay with, and then compared the results, and the results were they're equal. Fascinating, right? So
it was worse than that though, Barry. They had a preference difference between the two. More people liked the flat plane than liked the uncomfortable NTI, right, the way they left it.
Right. Exactly.
Okay, I'm going to throw this in, guys, because I think it pertains to this. Understand, the full disclosure, I think I've mentioned this before, I'm not an oral facial pain guy. You know, I just learned through these concepts through osmosis from my exposure to Dan and Barry. I'm a sleep guy, okay? So I watched a CE program put out by the Ontario Dental Association with Tenenbaum, an hour management of orofacial pain, right? And the only appliance he spoke about, he spoke about one appliance, and he showed it on his slides, and it was a flat plane appliance, perhaps maybe 2 to max 3 millimeters in thickness, and it only went from all the way from the posterior teeth to the first bicuspid. It did not engage the canine or any of the anteriors at all, upper or lower. It was purely biting in the posterior region. And that's the appliance flat plane that they recommend to use to help people manage their orofacial pain. That was it.
Well, okay, so first of all, to say you're going to help manage orofacial pain with an appliance is absurd. So that if you don't have a diagnosis and you don't understand trigeminal sigma.
Don't read too much into what I just said, because he did talk about trying diagnosis and all that other stuff. He said if you're going to go to use an appliance, this is the appliance we recommend using.
Well,
that's basically what I'm throwing out there to try and get some understanding of this.
Well,
this is the top guy in Ontario, the person that our college, our CDSO would listen to, right? It pushed come to shove.
Oh, that guy. Yeah.
Right.
Oh, I testified against him once. Yeah, I know. So yeah. Just saying. So yeah. So here's think about this. The orofacial pain guys have been spending, the specialists, the AAOP guys, the academics are spending their careers trying to divorce the concept of, quote, TMD, and I'm still upset with the term, but TMD and occlusion. Right? They want to. There's no relationship. You can't. You should be able to practice facial pain without a high-speed handpiece. You don't need to adjust a tooth. You don't need to do anything. You don't. You know they're trying to totally divorce occlusion. They look at the science and say there is no appliance therapy that is well evidence-based. So far, I agree that there's not a direct relationship between occlusion and TM and any joint dysfunction or pain management, a direct relationship. And I agree that there's no good science. Then they go and say, those that are practicing say, but you know what? There are many instances we just need to do oral appliances. Okay. So now we accept the fact when we look at Sackett, and we look what Sackett was saying when he talked about evidence-based medicine, that he said, one, we should have evidence, but two, we have to involve some level of clinical experience. So Sackett, that's where I've gotten my concept of we need the science to guide our art. It comes from Sackett. But you don't have the option that they take. And the option they take is, as long as you're using the science to the level that we're using it, and we can use art, but we know how to do it because we know the science better. So now we're just going to put in an appliance. It's not evidence-based, but we're going to do that. All right. But now I'm going to argue with you about your splint design because it's not the appliance we use. Even though I'm the first one to admit, one, that I don't have any evidence. So what do they use? They then say, while we don't have any evidence that our flat plane or the appliance, I've never seen the appliance you're talking about, John. I've saw the picture you sent us. But then they say, but at least our appliance doesn't cause damage. What's the damage you're worried about if you're using an anterior midpoint stop? An occlusal change. Wait a second. First of all, it doesn't cause the occlusal changes you claim it does. But second of all, didn't you just say there's no relationship between occlusion and TMD? So if we didn't make the TMD worse, but made it better, and our patient's still functioning, still chewing, still eating, and doesn't even know that there was an occlusal change, if there was one, why is that a problem? But you change the bite permanently. Now we're going to have to do ortho. Wait a second. What do you mean you have to do ortho? Do you do ortho on all the patients who come in with less than ideal bites? Well, no. So now this patient's feeling better and has a change, an occlusal change. Why do we have to go to get the bite where it was? Why? What is it? Where's the line? Well, you change the bite. You cause damage.
By that logic, that was the painful position in the first place. So
and I have tremendous. We're talking about Green, Laskin, Reed. Tremendous respect for these people, but sometimes they make, when they lose, they are as agendaed, and I call this a knee-jerk reaction. This is a knee-jerk reaction against someone that they see as an entrepreneur, someone making money. When I first brought the anterior midpoint stop appliance to Pete Dawson, Dawson hated Boyd, hated the NTI, had written battles with him. And when he saw I was doing that, he went crazy. He says, "What are you doing? Why would you be doing this?" So we explained to him what the concepts were, and I said, "What is your biggest objection?" It's the way he markets it. It's all that he's just taking advantage. He's making all this money. And we were at dinner, and I turned to him and said, "Oh, that's amazing, Pete. I didn't realize you were giving away courses and articulators." Of course, he's making money. He just didn't like the way he was making money. How crazy is that? So this whole thing about occlusion, and a lot of this is a knee-jerk reaction. Our academics don't like neuromuscular dentistry. They don't like it for good reason. It's really unfair to patients. They don't like someone saying where the joint's supposed to be. I'm going to move the jaw up and back, and then I'll equilibrate you there. That's interesting. Or I'm going to romance the mandible to where it's supposed to be. And they don't like it because they look at studies and they see what? There's no relationship. There's no evidence. There's none over where a condyle is supposed to be when the teeth are. It makes it literally, when you look at the science, putting a condyle in a certain place makes no sense. Right? When they look at an NTI, they think, oh, your goal, because this is how they use Lucia jigs, right, Jack? Your goal is to deprogram. We're going to deprogram the mandible and get rid of all these engrams, these muscular engrams, and that's going to allow the condyles to seat. That's what you're trying to do. And when people call an anterior midpoint spot, like a B-split or an NTI or an SCI in England, of the deprogrammer, we explain to them, no, this is not a deprogrammer. Our goal here is not to deprogram and relax the muscles and allow the jaw to go somewhere where I don't care where it goes. It's very simple. This is parafunctional control. We are lowering the forces that can cause damage to our patient and the dentistry we've done for them, while they don't have control of those forces at night, when they tend to be the most potentially excessive and have the potential to exceed the adaptive capacity of any of the components of the craniomandibular system. That's what we're doing. No more, no less. We don't care where the jaw is during the day. We don't care where it is at night. We don't care where your condyle is, when you're chewing, when you're eating, when you're sleeping, when you're kissing your spouse, when you're walking down the street. None of that matters. None of it matters, because there's no excessive force in the system when that's happening. You can't be causing damage. So they don't understand that. So they think that what we're doing is akin to putting the jaw in a certain place, a la shoving the jaw back, bringing the jaw forward into Gelb 4-7, bringing the jaw forward where your muscles are all relaxed, and yet when we do your applied kinesiology, you're strong when your teeth are together. They think that all of us are doing all of those things when we're not. We just have a little different design. And when people say to me, well, okay, so I use a night guard and you use an NTI. What's the difference? And what's my question? Well, Here's the difference. Let me ask you this. And anyone here who uses a night guard, here's the question I ask. What is the mechanism? What's the goal of the night guard? Tell me how it functions. What's your purpose? What's it doing? If you take an SSRI, we can explain to you about serotonin reuptake, and we can explain to you what its purpose is and how that could possibly resolve whatever it is we're dealing with. If we look at Botox, we can talk about the SNAP molecule. We can talk about how it affects the neuromuscular junction. If you talk to me about, you're going to put something in somebody's mouth, you're talking about an orthodontic, we can explain about the forces and how it's going to move a tooth. So now you've got a night guard because the patient's grinding and clenching. And I ask you, what's its purpose? What's the mechanism? How does it work? Anybody?
Can I channel Ramford?
Posterior support.
Who said that? Jack. They had posterior support. They already had back teeth. They had back teeth. This isn't a fully dentulous patient. That's very funny. That's really funny. So what's interesting is that when we look at a flat plane night guard, what we find is the following. Number one, we know that from our studies, when a patient opens, they immediately translate. There is no pure rotation, right? We all accept that. I don't see John's head bowing. I see. No, the other John. John Moses is sleeping, I think. Is he sleeping? No. Okay.
It makes sense. Yeah,
Okay.
You're right.
We immediately translate.
Our young dental students, so.
Yeah, exactly. I felt like I was in a classroom. We immediately translate. So therefore, when that patient closes on the night guard, where is, no matter how thin the condyle is, where is it in relationship to where it would be if they closed on their teeth?
Down.
It's down and forward. They are already somewhat translated on the night guard. Now they're somewhat translated on the night guard, which means there's a bit more potential strain on the lateral collateral ligament, the medial collateral ligament, the retrodiscal lamina, which is the posterior ligament. They're somewhat translated. And now they clench on that. And what we know is the vast majority of patients who clench while they're clenching on their nighttime appliance have higher level of EMGs than when they clench on their natural dentition. So you might say, well, therefore night guards are terrible. Why do they make some of my patients better? Why do a lot of my patients love them and they get better? They whatever it was, their joint, their pain, whatever it is, whatever they get better. Because they're higher level EMGs, that is in reference to the what? To the magnitude of the forces. Two things might have happened. One, we may have altered the direction of the forces so that if the joint was hurting before and now we alter the direction, even though there's higher forces, the joint might get better and get within its adaptive capacity. We don't know that. We just don't know. I'd love to tell you that I knew what I was doing. You know, when we put in all the appliances, we know exactly what we're doing with all the forces. We don't know that. It's ridiculous. Of course we don't. It's too complicated. I always tell this story when Harold Gelb, when I was working with Harold Gelb, we used to put in his moras, and we would put in his. When I go back to my office, I put in a mora, a mandibular orthopedic repositioning appliance, and patients come back, and 2 weeks later, don't we all know it? They all got better somehow after 2 weeks. The first 2 weeks is great. I think something new in somebody's mouth tends to have an effect there. Whatever is great, always. 2 weeks later, they come back and they say, you know, Dr. Barry, that pain that I had in my joint is starting to come back. Oh, and I go and I go tap, 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 and I see the dots weren't where they were before. How about that? So I adjust the dots and make them, now they're perfect. And don't you know, when I call the patient back in 3 days, what they say? Oh, it's better. And I thought to myself, my God, I'm just so talented. These hands, they're gold, right? They are. I mean, I've got it. You guys, you don't even, you shouldn't even try. You got me, because I do it. I can do it. And then I began to realize that if I wasn't so good at dentistry, why was I so good at this? You know, so where's the issue? What's going on here? And then I began to understand that it wasn't how we adjusted it. It was that we adjusted it. And whether there was some emotional component involved, I'm not suggesting that. Whether there was an alteration of force, magnitude, or direction by that change, whatever it was, seems to work rather consistently. So we know then now that if we put in this flat plane night guard and we get the patient where they're comfortable, even though the forces may be higher, it may be what they wanted, but what will help them. But we just don't have the kinds of controls over the magnitude and direction of forces that we'd like to have. At the same time, we do know that when we go to anterior midpoint stop, we do a tremendous service in terms of reducing the magnitude and making a major change in the alteration. Don's going to make me say something that I didn't say, so I'm going to beat him to it. There's another issue when it comes to orofacial pain, and it has to do with, it's not just force vectors, and it has to do with trigeminal signal. The trigeminal signal that is related to parafunction seems to be significant, and we think is playing a major role in helping us understand how these appliances seem to affect things like masseter pain, things like ligament insertion pain, things like central mediated pain, all the way to migraine. So some work has been done, and we've seen some initial work has been done, which has suggested some changes that we're seeing in the insula and the amygdala that with altered signal when there's anterior midpoint stops, Jack, as opposed to full arch appliances.
Can I say something here?
Please. Sure.
Barry, you reminded me of something that I read, seems decades ago. Some research by a guy named John Rue, a sleep physiologist, I believe. It's a long time ago.
Psychologist.
Was it out of Texas, I believe? And he was studying, so chime in if I get some of this wrong. He was studying physiology of sleep or psychology of sleep or whatever. And he happened to notice that a certain percentage of the patients that were coming and sleeping at his clinic had headaches and facial pain and stuff. So as I recall, he called in some dentists that were supposed to be experts at dealing with that, and they came in and adjusted occlusions and stuff like that, and the patients got better, like for 2 or 3 days or a week, and then it just recurred. So he as I recall, he called the dentist back up and said, "Hey, what you're doing didn't really work very well." So they were thinking that maybe they just didn't get it adjusted perfectly. Okay, so they come in and adjust it a little bit more, and the feedback they were getting initially was that, oh, that feels better, you know. So they thought they were on the right path, and John Rue continued his studies, and then pretty soon he got kind of intrigued with the fact that these patients weren't really getting better. So I think a long story short, what they did is they brought the patients, the dentist back in, and the dentist intentionally did some sort of restorative work that put high spots on the teeth. And lo and behold, the patients got better for 2 or 3 days. It was the change that made them better, not necessarily what they did. And then I think he did a study a few years after that where I believe he actually put some crowns on some teeth that were intentionally high, and maybe temporarily cemented them, something like that. And the change did make the patient more comfortable. That is probably about the time that I quit adjusting teeth for pain, unless there was pain in a tooth, like a lateral interference or something of that nature, was mobile or whatever. And then as you move through that process, and it's not long before you have to get into an anterior point stop, anterior program, or whatever you want to call it, something in the front that makes the back teeth not touch so they can't clench. And I have still used some night guards occasionally, but not in pain patients, because some patients have a lot of wear on their teeth, and it's either the muscles, the joints, or the teeth. They're kind of victims, or it can be all three. But if just the teeth are the victims, a night guard will work. It doesn't cause them any pain. It'll last longer, So anyway, that's kind of an interesting thing that John Rue you were, I think, supporting kind of what he was saying there in part of your conversation. So
Yeah,
anyway.
and that reminds us, Don, of
Nicolati.
yeah, Michelotti. I was trying to think of her name. So Michelotti's, and add to the fact that was so just before John tells you the story, just know that this is the woman I'm going to go see if I ever got divorced and was looking for a new wife. Okay, explain that, John. Don.
That's the whole thing. She's going to find my next wife for me. She's an orthodontist in Italy, and she found a sample of 32 females that were perfect. They never had a headache. They never bit their fingernails. They had no issues whatsoever. And what she did, she pasted gold or cemented gold leaf.
I don't believe it. I'm sorry. I don't believe it.
But and she published it, so
Right.
it made through
Now,
peer
come on,
review.
Don. You're
Unicorn.
You're the guy that throws things out just off the bat because you say there's no fucking way that's real. What I just said. Okay. Now you believe
that's
that?
why I love that.
I'm
That's why I
sorry.
love that paper. I can't wait to meet this woman and just it's hilarious.
The unicorn.
But regardless,
The
Yeah, the unicorn.
The unicorn.
so she sort of provided the proof for what you saw about John Rue. She showed that when you put interferences on, I think she went to first molars, put a 0.5 millimeter interference on first molars, she showed a reduction in masseter EMG activity. So the whole thing that dentistry has been dealing with since 1961, when Ramford published, was that interferences caused elevated EMGs. So John Rue showed it back when he did it. He was University of Texas, San Antonio. Michelotti showed the same thing. You put interferences on teeth, you reduce EMGs, at least temporarily.
And also, in all of these patients, all of them created no pain. So she didn't create pain. So this concept that interferences cause pain, this isn't, I don't even understand the term interference, but that's another issue. Interference to what and to when and when that occurs. Well, yeah, exactly. So,
and that all went with their theory of the lateral pterygoid. It all just snowballed into this mythology.
Right. And it's fascinating. I'll tell you, this is when I was asked to introduce these concepts to some of these concepts, other concepts about instrumentation and JVA and all that to Dawson. And in our discussion, we got to how we treat patients, etc. And Dawson sent two people to my office, and they spent a week, and they went back and told them about the appliances and what we're doing, and that's when they adopted the B-split concept, and at the same time, Pete was in John, I don't know if you know this story. Pete had contacted me to move to Florida to move my pain practice with Dawson. And I thought, honestly, that this would be it. This would be my opportunity to reach the dentist that I have not been able to reach. And obviously I have not reached. but that was my goal. And so we went down and we had several meetings, and I began to realize that Pete was giving. I mean, Pete was still of the concept that I was there when he told me that he can cure what was then reflex sympathetic dystrophy or chronic regional pain syndrome by equilibrating teeth. He totally believed that. He totally believed that occlusion was the answer to testicular cancer. I'm convinced of that. Having said that, we were making some headway. But Don, you know what it was. It was I knew that he would never be able to give up for his own legacy the concept of interferences causing lateral pterygoid spasms, mind you, lateral pterygoid spasms, which led to internal derangements, and that you could correct the internal derangement by correcting the occlusion. And he would never give that up, and I would never have lasted in that environment. So I didn't go. Yep. Fascinating, right? Well, hell with you all. I was fascinating.
I just kind of assumed that with respect to adjusting occlusion and getting those kind of things to get under control, I just wasn't good enough to do that. So,
well, and that's what he taught, and that's what he, you know, and that's exactly what happened. You know, you would go and you take his course, and then you go back to your office, and then you would equilibrate. And when you didn't get the same results that he did, you knew it was just because you weren't as good as he was. Well, I will tell you, I went to his office and I watched patient after patient, and some of them weren't getting better. And I watched Whit Wilkerson literally sweating on a patient, trying to adjust their bite who was in pain, with Dawson over his shoulder, making sure that they got every micromillimeter correct. And the patient, you know, and never, you know, they actually got in some trouble because what they used to do is they'd say, okay, you come to our office, or we're going to teach you how to equilibrate. But if you're a dentist and you're interested in being equilibrated yourself, you can come 3 days earlier, and we'll equilibrate you. And you have no idea how many dentists jumped on that. Oh my God, I could be equilibrated by the best. Right? Well, when the lawsuits started to come because they were equilibrating patients without discomfort and altering the parafunctional control, and even though no matter how well it was done, then developed some pain or dysfunction, they realized that probably this wasn't a really good idea. This is a true story. I was asked to speak at the American Equilibration Society. All right, that's kind of like what's the name of the Governor Wallace being asked to speak at the NCAAP event. You know what I'm saying? It's just wasn't a smart move. So I am speaking at this event, and I'm on the dais with, and one of the things they had that particular year, they had 3 different instructors: Whit Wilkerson, John Coyce, and one other one, I don't remember him. And they each gave a 30-minute thing on how to equilibrate, how they equilibrate. And Whit gives his thing, and John has a video. And he's got there's 400 people in the room, and John's giving a video. Well, first, tap, 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 grind, 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 tap, 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 grind, grind, grind. And then he says that there's magic words. How does that feel? Patient goes, well, it's a little high right here. Tap, 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 grind, 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 tap, 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 grind, grind, grind. How does that feel? Bite slowly. Where's it hit first? Over here. Oh, tap, 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 grinding. And now he turns around and he says, tap, tap, tap. And how does that feel? And the patient says, perfect. 400 people broke into applause, screaming and yelling. Oh my God, you got it right. I kept thinking to myself, so I'm this patient, And I'm going tap, tap, tap. And every time I give him an answer, he comes in and grinds some more. What do I have to say to shut this son of a bitch up? You know? And then, oh, perfect. All right, now he's done. And what did I say? What happens if you sit him up? It wasn't well received, my comment. Or bring him back in 2 weeks. So the question I ask you is interesting. Here's the question. If you're going to equilibrate a patient, what's the purpose? When does that equilibration matter?
I'll bite.
Yeah.
Oh, right.
I'll say something here that you can argue with maybe. So back just one step here. So a part of what else led me to not equilibrate patients for pain was you look at so many patients, most patients that had what you would term anything but ideal occlusions, and yet they had no problems. So I had difficulty getting past the part, well, if they have no problems, how can occlusion be what's causing this other patient their pain? There had to be something I was missing there. However, to answer your question, you made a point earlier that it's difficult to describe or understand what everybody means when they say an interference. To me, an interference is if when you begin to lose anterior guidance, or whatever you want to call that, and you start moving into group function. Sometimes in some patients, probably that have a lot of parafunctional activity, they may have an upper first bicuspid that begins hitting on an incline and gets mobile. Maybe it's pain, and you can adjust that incline and eliminate that mobility. The problem is it doesn't make the problem go away. You've taken care of that one tooth until things shift and change or another couple of weeks go by. So I just never really thought occlusion, it didn't take me long to get to that point, that adjusting occlusion just was not a real solution other than
Okay,
that kind of thing.
so I'm going to ask you something.
Yes.
You just made a statement, John. So we all understand, before I go any further, John and I are real dear friends and have tremendous love for each other. So as I'm about to destroy him, it has nothing to do with
Okay.
a lack of love.
Yeah.
I know it's okay. I know it, and I'm not really going to, that's silly. So John just said when you have an interference in excursion, right? So now I'm going to ask the question, when does that excursion take place?
You would have to think that normally, if it's going to cause mobility, probably during some sort of parafunctional activity.
Well, no, not if it's going to cause mobility. When is it possibly that interference going to take place?
Only when the
Are you
teeth touch.
walking, or are you sleeping, or are you lying down, are you on your side? Is that what you mean?
Yeah, when?
When the teeth touch.
When do they touch?
When they're not when you swallow, not when you chew food, during parafunctional activity. When you're
Bingo. That's my point. Bingo.
Bingo.
So when we talk about interference, so you kept all of your testicles. It's all good. So bingo. So when that there is no what we as dentists, we're taught to assume teeth come together. We think about if when you see a picture on a screen of someone in a dental course, what's the first thing you see is their occlusion with their maxillary, with a mandible tucked in the maxillary. Nobody thinks twice about that. Nobody says, I wonder why that patient was told to bring their maxillary and temporalis in the contraction and leave it there, even though it never happens in function. No one ever thinks that. We think of teeth like that. So when we say when it hits on an excursion, we just think that happens. No one stopped. So and then what happens is we'll sit and say, okay, fine, you're right, Barry, you're right. It's not when we walk, it's not when we talk, it's not when we chew food because there's no real force, or even when we swallow because there's a lack of force. 0.2 to 0.4 milliseconds at like 5 or 6 microvolts, and when we swallow, if they touch at all. So yeah, that's not force at all. None of that happens. It's only when you are, and then the very next moment you'll be thinking, and you'll think in terms of that excursion being in the way, without coming back to asking that major question of when. It's not our fault. It's how we were trained. We were trained that way. That's how we think. And it's really, 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 really tough to break. The T-scan is an instrument that tells us, that measures occlusion. And I say it doesn't measure occlusion, it measures occluding. It measures the action of, the verb. Occlusion's a noun. It doesn't occur without the verb. And in normal situations, those teeth are only making some contact, but not even an MIP, 20 minutes out of a 24-hour period. So those interferences that we're talking about, that slide that exists. Oh my God, that horrible slide from MI to CR. What are we talking about? When does that become an issue? When does that slide actually take place? Not when you're chewing. And is it all dependent upon CR? Who was it? Johnson? Don? Johnson said.
Lyle Johnston, yes.
Lyle Johnston. No procedure has done more to eliminate interferences to CR than the redefinition of CR. Come on, guys, that's funny. That's like a joke.
Barry, not that I want to take us off the occlusion thing, we can get right back at it, but we have Paul Alter here that has a couple of questions to ask about anterior midpoint discluding stops. I believe his questions revolve around that. Yeah.
Where are you from, and why is there a crib behind you?
Because that's where my wife puts me when I'm bad.
That's a great answer.
And then I go to that to get strong so I can go back into the room.
Yeah. There's a little bit of a bad boy behind the bars there. Yeah.
Where are you from, Paul?
Toronto.
Where are you? Toronto.
I heard you speak at the CACSDD.
I could never tell anybody I went there because I can't remember all those letters.
Oh, okay. Rothen's conference.
Yeah, no, I know. Yeah.
Okay. Yeah, so, well, the first question is, do those of you who use the posterior contact and those of you who use anterior midpoint stops, are you doing that because that's the way you were taught initially? And that's first question. Actually, there's part A and B of the first question. And B would be, since there are two different camps, do the camps ever get together and say, here's when you should or shouldn't use one or the other? Because that doesn't mean one's better than the other. There's advantages to some. For personal reasons, like the anterior midpoint stop, and that will be part of my second question. So let's go with the first.
I'll let other people answer since I've been talking so much. So,
Anybody else? You mean on a sleep appliance?
Yeah.
Ah, okay.
Okay. So I prefer anterior stops. I believe it helps. It better helps control parafunctional activity, potential parafunctional activity, clenching on the appliance. But for me, there's other agendas there too. It makes delivery easier. You don't have to worry about it hitting left or right or whatever. It makes it less of a potential problem that the laboratory can screw up this perfect mounting that you or by registration that you sent them, if we got it perfect. I'll say one other thing, which I kind of chuckle about when I read it. I was reading something here the other day where a dentist was saying that when you take your impressions, they got to be good impressions. Of course they do, but you also have to mark the midlines, you know, on the models, and so the lab can get that right. And I'm thinking in terms of with an anterior stop, why do I have to worry about all that very much? So delivery is just going to be very easy. You're going to eliminate, I believe, some of the parafunctional activity. Then you throw in a little thermocryl on top of that, which is not your question, and all of a sudden you got something that's pretty easy to do. So,
John, I have to say, I don't quite understand the comment about the anterior stop being related to the midlines being important or not important.
oh, okay.
Because
So-
it depends on which design appliance, you know, more than the mid stop, I think. But anyway, I'm just curious as to what
If
you
you
thought
use
about
a
that.
silencer and you're off center, you can,
Well, let me
might notice more.
say it this way, and I'm just giving information for Barry to crawl all over me here. So this takes courage. But so let's say you get the midlines off a little bit, okay, and you're going to have posterior stops in there, posterior contact. That would probably mean that one condyle has translated a little bit more than the other, perhaps, maybe. And that would mean what might look perfect on the lab bench doesn't look that way in the patient's mouth. It's not the same. So you deliver appliance and have to adjust it. Okay. If you happen to be using an appliance, say other than a tap, or maybe something that you titrate on both sides, like a dorsal or a Herbst, if you're already starting off with the midline off, then you're going to perhaps exacerbate that because of the design of the appliance when it's titrated. I think bottom line though for me is with an anterior stop, not only do I feel there's so many benefits for the patients, I just don't need to be that good. You know, it just works better in my hands.
Can I ask if you do it with a George gauge?
Yes.
Okay.
I do with the George gauge. I think there's a lot of different ways of doing it. The other thing I try to do is I believe that if you want to try to increase vertical, which I don't particularly design appliances where I fiddle with that much, because again, I think there's not much of a way we can tell what that should or shouldn't be. But it's easier to adjust the anterior stop. If I need to, then I adjust the whole appliance. I can add to it. I can reduce it if I choose to. If I then need to add acrylic to the posterior of it to get posterior support, which for me doesn't happen like hardly ever. But if I do, then I have this bump or stop or whatever you want to call it in the front. That then once I have it titrate a little bit, and I bite down on it, I've automatically got the right and left. I mean, I get the best articulator in the world I'm working with right in the patient's mouth when they add the acrylic to it. So that's just my thoughts and ways of doing it. So I'm sure there's lots of other opinions that work very well in other people's hands.
And
I
did you
don't make an
start
appliance.
off that way?
I'm sorry,
Did you
what?
start off that way, or were you taught the other way?
That's an interesting question. I came to sleep well after I was doing craniofacial pain, headaches, and TMJ and stuff like that. So for me, my own journey was it seemed like every time I went to a course or a class or heard someone speak, that became the guru that indicated to me what I was doing wrong with some other technique, and I needed to introduce this technique. And then after you do that for a year or decades, I was kind of dumb, it took me a long time, then you realize there is no one way that fits all. So then you begin to, I have EMG capability and stuff like that, which I don't use like hardly at all, like now. But that learning process from dealing with craniofacial pain, moving from left night guards to more anterior deprogrammers, okay, or NTIs, and the reasons behind it. When I got to sleep, it just became kind of a, why wouldn't you do it that way? I mean, so that was just my journey. So nobody taught me, you should put bumps on all of them. I just thought if that's where I got to in craniofacial pain, right or wrong, then I just moved right into a sleep appliance. It was an easy process for me. So, anyways, that answer your question?
Yeah, but I want to hear why, you know.
Why?
No, I want to hear like from the others.
Oh yeah, I'll be quiet. Yeah, go ahead.
I think the majority of the people on this session today all use anterior midpoint discluding stops. Is there anybody on here that does not use an anterior midpoint discluding stop or has not used an anterior midpoint discluding stop that could maybe speak up?
I thought you don't.
The only time I add them is when you'll run into a patient every so often that just clenches so damn hard, doesn't have pain, and destroys an appliance.
So that's
And
the only time
those
you had
people-
posterior. That's the only time you had posterior support, right? Okay. Now, Paul, did you just say you thought I don't?
Yeah, I thought you don't do the anterior midpoint stop generally.
I don't know when you heard that. I teach the anterior midpoint discluding stops at our programs alongside Barry. It's just the difference between Barry and I. Barry puts them on all appliances, and I put them selectively on appliances. That's that. But I absolutely believe in anterior midpoint discluding stop and the concepts.
Okay. So if I told you that I had a Somnodent that had an anterior midpoint stop made with a George gauge, and the back plastic still touched.
That's a problem.
Right. So not every anterior midpoint stop stops.
It just wasn't done properly. The stop has to be open it up high enough so you don't get posterior contact in the back. So that has to do with construction of the appliance. And that's one of the things you have to watch for. When you take your bite, you order an anterior midpoint discluding stop, you don't give them enough room. And if they're a little bit sloppy and you put it in the patient's mouth and you can see it touching on the back, well, that's the first thing you got to do is relieve that. And the other thing you have to watch for is if you have unilateral contact on one side only, you have to relieve that. And that's, although adjusting these appliances with the stops forward is less of a concern, side effect wise or adjustment wise than say the traditional appliance, you do have the concern that if all of a sudden you go from not having contact on the back to having contact on the back on one side only, then that patient is going to come in discomfort. So that's something if you're using an anterior midpoint discluding stop, you have to make sure there's no contact in the back from the get-go. And as you calibrate them forward, you have to make sure there continues not to be any contact in the back. Otherwise, you will have discomfort on the contralateral side.
Paul, I've seen that with Somnameds. They've always did a shitty job mounting cases. If they were doing something in complete contact, there'd be no problem. But if you want them to put a discluding element on it, I wound up adjusting the posteriors a lot to get rid of the contact.
One thing I did.
Even taps, Don. It's been very frustrating for me because repeatedly I've had to call the lab, say, look, if you have to open the damn thing up another millimeter. I mean, I give them 6 at least millimeters when I'm making a tap, if not 7. And they say if you have to,
they're not mounting them.
Yeah, well, that's, I think, what the problem is, because all too often I have to be adjusting those taps at the back end, and I shouldn't have to do that. Yeah.
I'm so spoiled with my lab tech in Allentown that was with Barry forever, and he knows more about taps than I do. So it's just a pleasure that I can get exactly what I want. I am spoiled.
One thing I've done with labs is sort of like Barry said, if you want a patient to clench and grind on something, put posterior contact in. Well, if you want a lab to make a thick appliance, just give them room in the back to do so. So what I typically do when I take the bite registration at whatever vertical I think clinically it ought to be, which is a whole different discussion, then I write on the lab script to please make the posterior part of the appliance as thin as possible. And then I take the responsibility if the appliance fractures, and it never has.
It's certainly one if you have got anterior contact.
Yeah.
The one thing, Paul, I just want to make clear. So, this isn't directed, but make sure everybody's on the same page. I hear an awful lot about bite registrations, and people talking about, well, do you do a George gauge? Do a pro gauge? Do you do a pharyngometer? Whatever. Well, my point is the following. using a George gauge isn't a technique. Using a George gauge is only a mechanical piece of equipment that registers your technique. So the fact that you use a George gauge with or it wouldn't matter if you used a George gauge and took a bite or you used tongue blades and opened a patient up and stuck in a bite registration paste. It's so I hear that a lot about, you know, the people are very, very critical of those of us who use George gauges because their technique's better, you know, and it just makes you laugh when you talk about bite registration. So the fact that you're using a George gauge I don't think was the player here. I think we've probably identified the player as Somnomed. For someone who knew that company extremely well, I can only tell you that when they came from Australia to the United States, they were one hell of a company. They were amazing. You would send their appliance to Denton, Texas, and they did exactly what you would expect them to do with that appliance. They sent it to China. They had it made in China. They sent it back to Denton, and then it sent to you, and you thought your appliance was USA made. That's the truth. That's why it was, when we first brought them here, it was 3 weeks to make. But when you want to talk about a quality appliance, it was incredible. It was a gorgeous, beautiful appliance. They've gone through transitions. I'm not at all connected with them. There's no company that I was once connected with that I'm still connected with. You know, you can make whatever assumptions you want, and I am told that there are quality control issues. Now,
Can I just say something on that, Barry? That's important about what you just said. Okay, the quality issues I've seen with Somnomed have not to do so much with the Somnomeds that Somnomed themselves make. They remain consistent with their quality. It's the fact that they license out different labs to make the product and use the logo, and that's where you start getting a lot of variance. That technician, how well trained they are, how much they're sticking to the quality criteria.
Does anybody know if they're still being made in China? Does anybody know that? I was just curious.
They're still made in Asia somewhere. I don't know exactly what country, but they're made in Asia. But then you've got, of course, you know, you have your local labs also making them, and so some of them are going to do it better than others, and that's where you get a lot of.
I heard great things about the Avant. Anyone using the Avant?
Yeah, well, I mean, it only became available in mid-January, so I had the opportunity to put in about, I think, 3, and I got 2 on the shelf waiting to go in, but I was shut down mid-February, March, right? So I've been wearing one myself personally since December 1st, and I can honestly say it's the most comfortable appliance I've ever worn, and I've worn an appliance since 1998. I've worn an oral appliance for sleep apnea. It is a very small, sleek, comfortable appliance. You know, I'm not going to say it does anything else better than, but it is a very comfortable appliance.
I've heard that. Yeah.
Can I get to part 2 of my question?
Sure, Paul.
Is that okay? Or
Sure.
step toes? All right. From my own personal experience of having had several different appliances, and eventually blood pressure going up and sweating like mad in the night and your heart's pounding and everything, sympathetic dystrophy. The only thing, so the Somnodent, so the increase the vertical, on the height of the thickness of the anterior midpoint stop, and that didn't do much for me. And the only thing that in one night got rid of all of the problem, all of that physiological nonsense, was using an anterior midpoint stop and a phonetic bite. So here I had a Somnodent with an anterior midpoint stop, playing with the vertical, but the back still touching. going with a phonetic bite. So now I've got a hyoid bone that's changing, and that's changing where my mandible's sitting. And now I'm not touching in the back, and yet the anterior midpoint stop is the same thickness or a little less than the somnodent. But I'm telling you, one night, and all of that stuff disappeared. My blood pressure started to come down again to normal after quite a while. And the other thing was that the phonetic bite's taking care of the vertical automatically, whereas everything else is just a straightforward movement. Like you say, we don't know what you're doing during sleeping, but at least when it's a phonetic bite, I know what I'm doing. You know what the patient's doing when they're speaking, as opposed to just sliding forward. So that was just my personal experience, and that's what sort of convinced me once I had the phonetic bite and an anterior midpoint stop that I could venture into the sleep realm a little bit, as opposed to, if no one figures out why I've got these problems, and these people are doing sleep for years, why would I even bother trying? So that was my experience.
All right, so let me ask you some questions.
Oh, really? I wanted this, Barry, but go ahead. Go ahead.
No, go on. No, you're good.
That goes back to why
Can we both take a shot at this?
Let me just ask one question. Let me just ask one question, and then we'll go into this. All right. Do you know who the #1 teacher of the phonetic bite is?
Yeah,
All right. So who is that?
Dr. O.
Okay, so Steve Olmos. So if Steve Olmos trains 10 people to take a phonetic bite, and then you got 10 phonetic bites taken, how many of them do you think would duplicate each other?
If they're verified with the motor reflex tests, I would say
Yes.
they're probably, if you looked on a radiograph, you couldn't tell the difference. And hopefully, if they're passing the motor reflex test being done properly, they should be, the patient hopefully will get a similar result.
I didn't ask that.
I'm willing to,
I didn't ask that. I didn't ask that. I didn't ask. Well, I didn't ask the results. I'm not talking about results yet. Talking about first of all, there's a mention of motor reflex test. You know that there's no validation, so you're aware that there's zero validation in anywhere of motor reflex test. Motor reflex was developed by John Beck, who teaches it to dentists because there's not a physician in the world who will, for the most part, unless they're trained, for the most part, there are a few. Steve has found a couple that will use that. And not because there's any objection to it, except for its total lack of validation. So, yes, assuming you would still pass the motor reflex test, and when we're done, after with this discussion, John, if you could share the screen, we'll show some videos of the motor reflex test. I think.
Oh, do you want to share? Do you want to share, Barry?
Let's you guys could go finish with.
Yeah, let's finish both answering the question, and then after you could share that. That'd be good.
So the people that don't know the motor reflex test will have a better feel for what's being discussed. It's never been demonstrated that what you said was accurate. That people will, even when they pass the motor reflex test. I've seen bites taken. I've seen bites taken on various patients that have come into our laboratory that were both done, and you say the quality, and maybe there wasn't they're nowhere near repeatable. So let's first ask this very important question, Paul. What's your diagnosis?
Well, the diagnosis doesn't have to do with the using a phonetic bite or not.
No. I'm not asking about the phonetic bite. I'm just asking about the condition that you're reporting that got better when you used the phonetic bite. So I'm just curious what the diagnosis is.
Well, I don't know what the dentist diagnosis was, other
No,
than
the dentist. It doesn't matter if it's a dentist, if it's a physician, if it's I know what you know. You're reporting
mild
some
obstructive.
sympathetic. So were you was that where you tested and diagnosed with OSA? Yeah. What can you describe the conditions of so AHI arousals? What were the details of your diagnosis, Paul? Do you know?
I'd have to fish out the results.
Don't bother. I mean, but whatever they were, you were experiencing awareness of sympathetic bursts with sympathetic activity that resulted in significant symptoms during that would actually, sounds disturbing, like they would wake you at night, etc.
It was about 10 years later when I started getting all of that. But in that first 10 years where I didn't have that kind of stuff, I just still didn't wake up rested. And a lot of that was the clenching. I ended up having, a lot of clenching was doing a real number on me. It was vertigo, problem with heights, problem with wide open spaces, turning my ankle all the time, like so many like just postural neurological things that were going on and on for like getting worse and worse and worse. You know, people think you're a nut when you say, I get vertigo when I go up in a plane, but I never used to, but I don't get vertigo going down in the plane. And, eventually, through Steve's course, once I understood more about neurology, it kind of became obvious why these things were happening. So I had a sleep issue and I had the joint issue and inflammation of sensory motor nerves. So when I see how quickly things turned around, it makes you think you really should know whether somebody should not be biting on their back teeth and who can bite on their back teeth, because it'll make a difference to how much disruption of the sleep by the time they wake up. So that's when I had an anterior midpoint stop with the SomnoDent, and yet still woke up tired. I didn't know about back teeth touching and all that at the time. So when I fished it out, when I did find out, I realized, yeah, it's touching at the back. So, curve of speed.
Even with the anterior, so you ordered an anterior midpoint stop, but it was still touching the back. Yeah.
I had one that didn't have the anterior midpoint stops on the dent. Then I had another one made that did have it.
But you were still touching the back.
Still touching.
Even with it. Yeah. So did you adjust that prior? Did you ever have a SomnoMed, an anterior midpoint stop appliance that wasn't touching in the back?
We tried to adjust it, and it still wanted to touch in the back. We made the front thicker, and then I started getting a lot of muscle problems, and my joint was hurting, so we had to cut that back. I have a significant cant that also was now not present, which was present in the SomnoDent. I remember asking about it, and I was told, you're hyper focusing on all this, and yet with the phonetic bite, there is no, the cant is adjusted for. And so, I started to think, is it the George gauge? Is it the phonetic bite? Is it the eliminating the cant? Is it, there's so many little factors that figured into me that I figure, well, why have these hassles with my patients? Why not just do it the same way? And then I'm going to take care of all this stuff. And for someone who hasn't been doing it for years and years and hasn't done a ton, I'm having very few headaches with it. Whereas if I would have gone the route that was done on me, I would have quit.
So you're saying by using the phonetic bite, it's simplified things for you.
Reflex tests, yeah.
Okay. So Barry, can I just
So
jump in
there's
here? Can I? Or you want
There's
to
a relation-
continue?
Pharyngeal compliance. I'm not in trouble with it. Yeah,
Okay,
Yeah.
so
No, good.
my understanding,
Good.
yes, sir. So my understanding here, Paul, is that you were doing it sort of the way we were originally taught, to do this standard fare, and you're having all these issues. The moment you went to phonetic bite and then, motor testing, and all of a sudden everything got better, went away, right? So you're on your study of an N of 1 person, right? This worked. Okay. So what I'm going to tell you, okay, is just my opinion here, is that the only thing that changed between the original position you were in and the position you ended up in, that actually was a better position for you, physiologically a better position to manage your sleep issue and got you into a better place, was the fact that it was in a different position. I don't believe for a second that it was the phonetic bite that took you there. But you'll go on your journey and you'll see. At the end of the day, we had an open discussion online on the Sleep Disorders Dentistry blog a few years ago, and my God, everything under the sun came on there. People were doing it, golf tees, using golf tees to take a freaking bite. It was amazing. Everybody describing their protocols, and really, the interesting thing is that they all use the same objective testing at the end to see that it worked. And so you could get to the end result all sorts of different ways, the jaw ending up in different positions and still end up with a satisfactory outcome, which right there, I think is, plenty of evidence that it really don't matter what you do. You just got to move the jaw. Where you had your jaw before in the previous attempts was just not the right spot. Right? Now, you happen to hit it with the phonetic bite. I'm going to say that was fine, but it's not like it couldn't have been hit another way. It's not the phonetic bite, I don't believe, that took you there. But before you respond to that, I'm going to just share my screen and show you folks something. Application. Okay. So just 2 slides. Going to come up here momentarily. You see that? Can you guys see that?
Yeah.
Okay. So 4 years ago, whatever, I bumped into a guy named Daniel Clower at the ADSM. Didn't know him from a hole in the wall, and he's talking to me about using the phonetic bite, and I literally looked at this guy. Okay, so you read the study, right? Basically looked at this guy and said, does that fucking thing even work? That was exactly the words I said to this guy taller than me that I just met for the first time. And he goes, of course it does. So what came out of that is he populated a spreadsheet with 20 consecutive patients. I did the same thing. And you can see on the blue chart here is that data basically showing that, yeah, you used the phonetic bite, I used George Gage advancement, and there was no statistical difference in the outcomes.
As far as
no reason to believe that we're in the same spot with him taking phonetic bites and me advancing using George Gage, right? Although we didn't evaluate that. And then the second chart you see there is the fact that, let's see, there was 4 offices, 5 cases from each office. These were not consecutive cases. They were cases that were submitted to the ADSM for accreditation or diplomat status or whatever. And Steve actually asked us to do this, although I told him that there's nothing scientific about this. These are selected cases, unlike the first group. But I guess he just wanted to rub it in the ADSM's face, say, look, even following all your protocols, these guys are all diplomat, the phonetic bite still gets good results, which is exactly what the only thing this shows, is that using the phonetic bite, being trained by the ADSM, look, there's no statistical difference using George Gage versus phonetic bite, okay?
But the study was just about the AHI part.
Right, of course.
Well,
I'm not talking about the other symptoms.
My AHI right down.
That takes a discussion to a whole other plane. I'm just talking about effectiveness with AHI reduction because it's simple for us to evaluate that and get that objective verification. And that's what this was on. What I'm going to throw out there, and then I'm going to give it back to Barry, is that honestly, I really think that your results more had to do with just ending up in a different spot that was better for you. And okay, so I buy it. The phonetic bite took you there, but that doesn't mean it's going to take the next person there or the next person there. The study I just showed you is the only study published in the literature actually having the phonetic bite paired up with pre and post sleep studies. Are you freaking kidding me? All these years, and there's never been anything published with, pairing up phonetic bite with pre and post actual objective sleep studies. Why not? That's why I was completely unbeliever, just a few years ago. So I went through that exercise. It was really more to be an exercise just to see. It was never intended to be published, but we thought it was interesting enough. Okay, let's publish it. But it would be, with the length of time that has passed, you would think there'd be all sorts of documentation out there that you get improvement in all of these things, when you use the phonetic bite, as opposed to just advancing, versus a tool, using George gauge, pro gauge, SOM gauge, I don't care which gauge you use, right? But there isn't anything published showing that. Why is the question? And you can't really hang your hat on an N of 1. You can just say that, well, I had a good experience, right? And that's really, all I have to say on that. Barry?
Or an N of 10 with 10 of my patients, or an N of 20 with 20 of my patients. I mean, it's what's called confirmation bias. And I understand there's a tendency to
No. Sorry, Barry, I'm going to disagree with you here. 20 consecutive patients in each
I would say
office.
20.
20 on
I
our
didn't say,
there's 20 consecutive
but
patients in each other.
We're talking about resolution of inflammatory neural activity. We're talking about solidifying through proof, through neuromuscular, motor nerve testing, etc. It's a, I've seen it. I understand the believers that come that this creates, and whatever. It's not. I don't mean in any way, shape, or form, Paul, to discourage, and whatever you want is fine. But if we're looking at any level of evidence beyond, when we look at it, at the structures, and when we look at the beginning, and if I could explain at length my history with where all this came from, and etc. It's long and complicated, and it's really not worthy of the length that it takes. But I do get concerned about the assumption that what we're doing is why isn't everybody should be doing this, because it's going to make everybody so much more healthy than simply resolving their obstructive sleep apnea. That we are doing so much more with this jaw position that's determined by an awake parameter, when there is no evidence that there's any relationship between awake and sleep parameters. So,
I'd love to see it studied, Bear. So
yeah.
I would love, in a perfect world, to have John make Paul a Somnomed with a different bite and see if the balance symptoms came back.
On a study of one, you could do that.
But still, just would love to see.
Go for it.
Because what we've established here,
why general anesthetic works, and I don't know whether there's research that shows why when you strike a patella tendon and it doesn't respond, why that tells us what it tells us.
So therefore, we don't need science, Paul.
No, therefore, just because we can't do much with the motor reflex test doesn't mean that it doesn't have validity. Although there is one randomized controlled trial that Beck did that actually his method worked out better than two machines for carpal tunnel testing. That's the only one I could find.
It's possible. I don't doubt that.
Don, you have a quizzical look on your face. Are you aware of that study?
Almost makes me crazy. And Paul, I love that you're better, and that's all that matters. You know, at the end of the day, it's
No, but I'm also
it's
happy
just
that
to
it allowed me to do something for my patients so that I actually get somewhere, as opposed to all the other hassles that I did go through when I tried it and that people went through with me. And, you know, it's just that it works. I'm not saying it's better than one or the other. The original question was, some of us use George Gauge, some of us don't. Isn't there something that all these people who do it differently can get together and say, here's when one might be working out better than another?
You know, so when we start talking about bite registrations, interestingly enough, it would be so simple, and it's what I say to all of our pharyngometer people, Paul. It would be so simple if you're telling me that you can take a phonetic bite, and you know that that's where the jaw is supposed to be when we're that's the best position for this patient. And then I'm telling you that I have another technique. It happens to use a George Gauge, and then we titrate guided by objective studies. So let's take the 20 patients. Very simple. Put them in a phonetic bite, test them, then have them go through what you're referring to as the others, the normal processes, and test them, and look at the results, and compare those 20 patients. That would be a simple thing to do. I've been saying that to the pharyngometer people who claim that they know where the jaw is supposed to be based on an awake parameter. And I compared that to the neuromuscular people came after me. Dickerson came after me and wanted to do he didn't like my George Gauge. I just laughed that somebody's upset with you taking, as I said, it's not a technique. It has nothing to do with the technique. But he didn't like, your George Gauge sucks. We know the right place to put it. I said, okay, great. So we can take a neuromuscular bite. That's where the jaw is supposed to be. Right? And we get everybody's head, neck, and shoulder better, and we get rid of testicular cancer when we put in our neuromuscular bite. So I said, fine. Well, then you do your neuromuscular bite, and then I'll take the same patient, and we'll go through the entire process, and then we'll compare. He says, oh, that's not fair. You'll be titrating them. I said, no, but your claim is that you're getting the bite where it's supposed to be. I don't make that claim. I make the claim that it's the entire process. So take your process to our process, and we'll compare. I would love to find out that the neuromuscular bite's the best place to be.
I'm not saying
give
that
me some information.
mine puts them where
Okay.
they need to be. I'm just saying mine seems to make it easier on the beginner to have less stuff to worry about. Like John was saying, that, you know, for certain reasons, why it makes it easier for him to use an anterior midpoint stop.
Yeah, but I don't find the guys I teach are going through anywhere. I'm not sure what you went through, but I don't find that to be common. So I'm not sure what we're correcting. But that's, you know, no one said no one said if someone's telling me, and it's what I've heard, it may not be what's being taught, but it's what I've heard, is that not only are we getting AHIs better, but we're lowering inflammatory state, and we're improving the body, and that all pain is related to some sleep problems, and the more people are having sleep problems, and then if you put in a maxillary appliance or you put in a night guard and you haven't slept, you haven't adjusted someone, you haven't tested their sleep, you are malpractice. I know I've heard that. Which if that's what I'm hearing, that no, I got a problem with that. I got if someone's saying to me, this is a starting position that I really like, and I use motor nerve testing to check it. I don't care what you use to check it. That's what makes you, if you feel good about that, it would be better if we therefore use that motor nerve and validated it. I say that I use joint vibration analysis. It's something I really, really like. Not their EMGs, but I find it useful information to me. I have problems with it because it was never validated. Not once did they do a good job validating the information that it gives me. And so it's a real problem. And I would be careful telling Danielle Manfredini or Chuck Green that I use joint vibration analysis, because they're going to attack me pretty aggressively. I would say the same thing about this. If we're going to use the motor nerve testing, Dr. Olmos, why aren't you validating it? Why are you selling it, or whatever you're doing with it? And you may be helping a lot of people, and you may not be. You may be taking some people down a road that maybe they didn't have to go. Maybe there are people doing more than they need to do to get some of their patients better. Because it makes them better, because you have anecdotal improvements, that's really not enough. So did DK. So did Gelb.
The improvements as far as like the neurology and the orthopedics, that was from the TMJ appliance during the day. That wasn't the sleep stuff. The sleep part was just the sympathetic dystrophy and feeling rested in the morning and blood pressure. I know there's nothing I can prove, of course. It's just that's what happened, but I can't. You know what? Like you once said, if everything has to be with a randomized trial, then we're handcuffed. We can't treat anybody. So you have to have the science, and then you use your instincts.
The science to guide your art, absolutely. And I'm just asking that the science that he's using to guide his art be more validated. That's all I'm saying.
So Paul, the bottom line is that without science, you use the science to guide the art, like Barry just said, but then once you think you have a concept that's worthy of testing, you test it and you get some data in the literature for people to say, hey, and now I have some confidence in this. That doesn't happen. Time goes on, years go on, and things are being taught as this is the way it is. And based on what? Okay, do you guys see a document open on your screen?
Yes.
Okay, so I just wanted to show you this. So this is the 20 consecutive patients on George Gage, 20 consecutive patients using phonetic bite by Daniel. And over here, I don't know if you can see my cursor running around a circle over here. Right here. So the phonetic bite, 1.1 adjustments per, like was the average adjustments. Okay. George Gage protocol 2.35. Now I start my patients very conservative with advancement. So I take people through a few advancements before I get there. So that's my explanation to why he from the phonetic bite, he adjusted people, most of the people, just one adjustment forward, one mil forward from wherever he took that phonetic bite from. Now, a little bit lower down overall, it basically, out of those 20 consecutive patients, the standard adjustment, average, I should say, was 0.9. So some of us have been 0.5 and 1 and 1.5 or whatever. So 0.9 mils forward from this phonetic bite in those 20 consecutive patients. And I was 2.8 mils forward from my starting George Gage bite in those 20 consecutive patients. So, I mean, the only reason I brought this up, Barry, is because you mentioned, it'd be very easy to sort of do a comparison. No, but you don't want them to adjust their phonetic bite. Just take a phonetic bite. And now let's compare it to our adjustment method using whichever gauge you want. Well, here, in a sense, what we're looking at is that they got it pretty close with the phonetic bite, but they did have to adjust it forward, right? To end up with statistically the same result in the end outcome, HI-wise, for patients. Okay, so I just wanted to share that. And it's not like a 1,000-patient study. It's like 20 consecutive patients. That's it. This is the only insight we have in the data in the literature. That's all. There's nothing else for us to hang our hat on. unless somebody wants to do a study, and that would be Steve, which should be actually, you know, like he's had plenty of time to do this. And his answer when I've asked him is, I'm too busy. Well, you know, if you want to keep promoting this thing as being the be all and end all, well, you know, I think that's important.
Are you going to have science behind? No offense, but are you going to have science behind you, or are you going to have believers behind you? I've never asked anyone to believe anything that I've said, and we're all very, very careful to differentiate between what we know and what is known, and what we and where we take the liberties of art to apply it with as much science. And even when we use art, we try to use as much science in that art as possible. It's okay, Paul. I'm sorry.
One thing that you could do is do a CBCT on the person with the George gauge, do the phonetic bite, do CBCT on that, and then without anything in their mouth, and then see what's the change in their three-dimensional airway when they're awake and standing up.
Please tell me you're kidding.
Yeah.
Please
Well,
tell
you're
me you're
looking
kidding.
for some science.
No.
That's not funny, because that what so you have to explain to me with your why that would be totally irrelevant.
I would think that if you're using, well, it's not going to say one method is better than the other. It's just going to say that advancing the mandible gives you more three-dimensional space.
All right. So you understand, Paul. Listen to me carefully. You are looking at an awake airway. It has
Standing up.
nothing to do. It has nothing to do with what happens at night. Nothing. Zero. Why?
Which is why sleep medicine uses sleep endoscopy to try to predict, because they know it's different.
Wide airways will collapse. Narrow airways have the potential to stay patent.
Bottom line is, Paul, there's nothing in the literature that demonstrates that changes in airway during awake is related to what happens with AHI reduction during sleep. So that's why we can't use it as a predictive tool. There's a relationship. I'm going to say there's a relationship in that if you get the airway to stay more open or be wider, it tends to be associated more with a better outcome. But the problem is you get people that you open up their airways really big and they still have sleep apnea. And you get people that really don't respond that much that don't have sleep apnea, like it's resolved. There's a lot of crossover. So, you know, it's meaningless information to evaluate the airway during wakefulness and use it as a predictive tool to whether an appliance will be effective or not. So that's not the study you want to be doing.
Well, have there been no people, either people who sing or people who are linguistically knowledgeable, that when you say certain sounds, your hyoid bone moves in such a way that your airway is more open?
So clearly we understand that with obstructive sleep apnea, the hyoid bone in rest will change, and the position from its gonial angle, if it's higher than a certain, increases the likelihood because of the muscular changes. But it has where the hyoid bone is and what those changes are in an awake person has never ever been correlated in it. No awake parameter has ever been well correlated to the likelihood of sleep apnea. Period. That's what makes this relatively difficult to explain. I'm not saying that,
But Paul, what you might see though, you might see somebody show you a paper where the mean of the two samples shows a trend, but there's always huge overlaps. So that goes into the study of literature and knowing the difference between clinical significance and confidence intervals. So it just kind of brings in a whole nother discussion of how to read a study that you could be shown. So, but what John said earlier, there's just huge overlap between the samples.
Well, I guess then the only thing that's left is the people who are the really difficult cases. you try it both ways, ask the person how they feel. That's not scientific, but
Well, try what both ways? I don't understand.
oh, just one with George Gage and one with the phonetic bite and
And ask
using
them how they feel at the chair. You mean in a chair? Give them 2 bites and see which one they like better.
the 2 appliances.
Is that what you're
Well, that's what Don was saying before with me.
Yeah,
No,
no.
no.
He was saying it would be interesting to do a little study. But Paul, really, you know what? If you found something that works for you, there's a lot of people that use the phonetic bite, and that works for them, and they're happy, and they've got a system that takes their patients to where they need them to be, and that's fine. You know, and you got other people that got, you know, like Brad Eli was on the webinar yesterday. I mean, he is a top guy in the field of orofacial pain and sleep. He uses wax bite plates. Get a few layers of wax bite plates. He positions the incisors where he visualizes them that he wants it to be, and he registers a freaking bite. No George Gage, no George Gage fork, no Pro Gage, you know, no sounds, no phonetic sounds, right? So, and that works in his hands. So,
I don't think so. But that's
well,
another.
come on. You know, we're all working towards that same test in the end, was the objective resolution with the sleep study, right? So, Paul, what I'm saying is, I'm not going to discourage you from using a phonetic bite if you think it's doing the job for you until it doesn't. But I don't know that you have enough evidence to be able to go out and promote it as being, okay, this is what everybody should be doing on what you've got going right now. You're still going up that curve, you know?
And
you
keep this in mind. Keep this in mind. There are patients that have had quote unquote George Gage bites that went into an almost trained office, used a phonetic bite and resolved the problem. Absolutely. And I will tell you of dozens of phonetic bite cases that came to us that we resolved their problem, that they were in pain or discomfort, it was too much plastic, et cetera, et cetera.
But
So,
the net result is that you put the jaw in a different spot. And that's what resolved the problem. It wasn't really the George Gage or the phonetic bite in either case. That's right,
that's
Barry?
my point. That's my point.
Yeah.
My point is that it's not. And when you're looking for a resolution, you asked a really great question. Who's using the bite? Why? And are there times that you don't, et cetera? And the reality is that when it comes to resolution of the airway, no matter how we've looked at this, we've been unable to define the best bite registration technique. The Matrix Plus is probably as close as we can get to predictive value because we've got a sleeping patient. But is it ideal? No. Are there problems with it? Damn right. There are lots of problems with it. I don't argue with the way anyone takes a bite until they argue with me. You're not. Until they argue with me about the way I take mine. Does that make sense? I don't find it. Yeah, go take it, do it, but don't tell me that yours is superior. That you're going to take care of the head pain, neck pain, and all.
The question was, when is one way going to do a better job than or not a better job, but they have less. Like, what's the diagnosis to see? Oh, I have this problem or that problem. I should use that way or that way. That's
it doesn't exist. Doesn't exist. Doesn't exist. And no one likes that answer. There are reasons that more people go listen to Almost than Glassman, and one of the reasons is no. Well, I don't understand why, because I'm really kinder. But when you can't argue with me, and I won't take offense. One of the reasons is that when we don't have the answers or the answers aren't known, we say that. That's a little frustrating. People want answers. They want to be told. So there's a tendency amongst those who are teaching that when they don't have the answers, to make shit up and combine things. And then when it works, we've got what we call confirmation bias, and we start to believe it. And it can work. There's no question. You heard earlier, I don't know if you were on when I talked about adjusting appliances, and I adjust appliances, and somebody knows, well, so how do you adjust it? What burner do you use? I don't even know. I'm just adjusting it because it looked like it needed adjustment. I mean, I'd love to give you the answers. When patients have stylomandibular insertion tendinosis, then we use this particular appliance and we make sure the contact's here. Oh, yeah. No. When patients have true migraine with aura, this is the appliance we use. And when patients are canted, what do I do? And when my answer is I could care less about their cant, care less, because no studies demonstrated a significant existing problem that occurs on a regular basis. It's predictable with a mandibular cant. It's kind of like when you look at patients that come in your office and they're in pain and you see they're in crossbite and you go, oh my God, they're in crossbite. I got to fix their crossbite. Totally ignoring the fact that the last 30 patients you saw in crossbite didn't have pain.
It's interesting that you say that, because when I had the first Somnodent, I cracked it on the right side that had the screw. So they put a new screw, cracked it again. Then they just fused the thing all together so it wouldn't crack. Then when I got the next Somnodent, the same thing happened. Where's my high cant? I'm like this on the right. I don't get that with the phonetic bite. But I had the anterior stop and was still breaking it in the back. So in my case, I think the phonetic bite, whatever it did three-dimensionally, allowed my teeth to be separated enough. But both methods cleared up the
I can separate your teeth as much as I want without a phonetic bite. Irrelevant. I can separate them. If you think, if whatever it was, whatever is creating those forces, if increasing the vertical was going to alter those forces and allow that appliance not to break, so be it. I would strongly suspect, no offense, that there was other ways to reduce those forces. I can't say what they are. I can't. All I'm saying, but if opening your mouth reduced the forces so the appliance didn't break, so be it.
Okay, so to answer this question, this is for everybody. So I watched Dan Lewandowski do the apnea guard on Elaine, and I'm thinking, like, wow, that's like a whole mess of stuff in your mouth and trays, and we're wondering about verticals and stuff like that. If we have all these different ways and all these different outcomes that really we're kind of waiting to see what happens, and then we figure out what are we going to do. Why does anybody make a nylon appliance that can't be made more you can't increase your vertical, you can't really do much except back and forth? Why not go stay with plastic until you figured it out and then make the nylon?
Because the truth of the matter is that most of the work done, whether you appreciate this or not, but there's very good lit looking at vertical dimension and the likelihood of it making a significant difference, and it's not very impressive. So in your case and in all of your cases, whatever, I doubt whether the cases you've treated, I won't make.
No, you're not insulting.
No, I don't mean. I have a.
Say what you do, and then if you're going to back it up, that's fine too. Just say it.
No. What I'm saying is that it's, and I don't know. The reason I'm not saying it is because I don't know it. So I don't know your cases, and I don't know why you were having the troubles you were having, and why whatever you're doing now resolve those. I am going to say that the people I've worked with and people I've trained, and there are 1, 2, 3, 4, 5 on this call. Didn't have those issues and are successful treating sleep without going through whatever you're going through that this resolved for you. I'm not saying I would have resolved whatever was creating all of those troubles you were having with sleep. I can't say that, but I can say that it's not common. And I'm looking at Paul and I'm seeing a young Barry Glassman. Okay. And I lived through you, Paul. I lived exactly where, because I had patients that I didn't have explanations for. And I went and I met Niles Goucher, who taught me, and I watched, and he took condyles and he put them into the external auditory meatus so that patients couldn't hear, but they sure could feel better because they could bring their teeth together without any interferences, and it was consistent. They always bit at the same place. All right. And when I did that, their head and neck pain went away. They didn't have any chins, but you know, you can't have everything. And believed it, lived it, carried his flag, saw him as, oh my God. And then I met Harold Gelb, who just ripped me another asshole in a meeting. Much worse than anyone's doing here. Just it totally destroyed me in front of 400 people at the university, at Temple University, and then took me out to dinner. And then I developed a 7-year relationship where I worked in his office, and everybody else was wrong, and I had to move the jaw downward and forward in the ideal jaw position, and muscle tests with applied kinesiology. No, we didn't use motor nerve testing, but used applied kinesiology and got everybody better and whatnot, until one day I said to him, you know, this today, let's use the applied kinesiology, but today you won't know who's wearing the appliance. He said, oh, Barry, don't be silly. I said, no, seriously, let's do that. He said, sure. So I would go into the office and put the appliance in or not. And then he would come in and do the applied kinesiology, not knowing whether the appliance was in. He was wrong 60% of the time. I was never allowed back in his office. So that relationship was over. That's true.
That's something I would do.
If I can say something here, I experienced everything Barry did. I mean, I went through all that kinesiology, Gelb, Dawson, Niles, and all that stuff. And in the bottom line here is, because I sometimes have not very many people ask me because they don't really care what I do, but sometimes I'm asked what bite registration device I'm using, as if it's some sort of magical approach. And you know, I look at a bite registration, it's just this thing that allows me to transfer where I think the patient ought to be, however I decide that, to a laboratory. And they don't get that right very often. So if it works, it works for you. You know, if it worked for you, hey, great. You know, if it works for the rest of your patients, even greater. But nothing works for everybody. There is no magic. There's no magic there that works for everybody. That's kind of what happened to me on my journey. I learned all those gurus were right some of the time, some of them most of the time, none of them all the time.
Yeah, but the problem, John, is that they pretended they were.
Oh, absolutely, absolutely.
So Niles told me everybody got better until I spent time with him in his office. Gelb told me everybody got better until I've watched Gelb, and I've watched
me too.
Other people, Paul, in their practices. And I watched them intimidate their patients the same way they intimidate their audiences. And therefore they are totally convinced, and they convince themselves and they convince their patients that they're better. You're not that. You're too caring, you're too honest, you're too good for that.
Well, guys, it's 4:54. I think we had it.
Wow.
You know,
Thanks, Paul. This one, I wasn't going to stay 2 hours.
That was actually a great contribution, that discussion.
Yeah.
Interesting.
That was great.
Hopefully you got something out of it, Paul. I don't know. We got some questions answered. I mean, I think it's been a great session. I didn't know, because we just did the anterior midpoint discluding stops yesterday. I didn't know if that was a little overkill. Next Wednesday, the topic that's on the books is, do you have to be a TMD expert to make OSA oral appliances? And once again, if we get through that, you know, quickly, you know, we can move on to any other side topics you want to discuss. And if there's any thoughts about what you'd like to discuss next time, just shoot me an email, and I'll make sure that it gets on the agenda and mentioned up front today. Is there any other closing remarks anybody wants to make before we I'll go away and get some dinner?
Well, there's
Yeah,
some people that are on that haven't shared. I just want to.
What's that?
What's up, Paul?
I want to thank you for letting me hog the time, because I've been
Oh, it's great.
dying to ask Barry this for 2 years.
There you go.
God help us with 2 berries. Oh my goodness. Berry in the making. God help us. There can only be one. There can only be one.
Yeah, tell my wife. She's praying. Actually, she would like there to be less than one. I can't understand that. So I'm wondering. I wonder if there anybody that hasn't participated. Thoughts? Anybody? Howard, Steve? Anybody? Any thoughts on the discussion? No.
I don't think John said a word the whole time.
What?
John.
What, is it?
Which John?
Is this Howard from Staten Island? Is that you, Howard?
John Boozy's been talking.
Yeah. Howard, is that you from Staten Island? Yes, no?
Just unmute it.
So, by the way, let me mention that as far as I just announced 3 more by Corona webinars. I sent emails out, and also you'll see it advertised on LinkedIn. There's going to be one coming up next week on the Snoozeel, which is out of the UK, and it's basically a device you place on the tongue during the day, and electrical stimulation helps to build up the tongue muscles. And they actually have data that Dr. Sam is going to be sharing on the effectiveness in managing mild sleep apnea and snoring. And right now they have an ongoing study. I think it's 100 patients in this second study where they're evaluating moderate to severe sleep apnea. So it's going to be interesting. Hopefully he has some data to share with us on that one by next week. And we have Dr. Elaine Chin the following week talking to us about COVID products. I'm talking about antigen testing devices, kits that are available to us, and all sorts of other products that help make the home and the workplace a safer place. This is a family physician, and very, very much a trailblazer. So I think that would be interesting. And the following week after that, we have Jeff Weiscarver coming on and spending 45 minutes with us on the circle. I asked him to come back and do a longer presentation because I was so impressed with the little bit he shared with us. And I know that I'm going to definitely be ordering some to use in my office for calibration and follow-up. And we'll see. Until we get using it, we won't really know what it's like. But right now, it certainly sounds very promising. So I asked him to come back and do a webinar with more information on it. And these dates are you'll find them all online. You'll be getting emails.
Jack, did you hear the first Weiscover discussion of the circle? Were you there for that? Maybe not. Jack.
Who you asking, Jack?
No.
I don't remember seeing Jack. Dorothy, I don't remember seeing you on that.
So this is kind of fascinating. This is it's a ring, and it picks up. It's got a pleth signal, so it does suggest sleep staging, but it also gives an ODI and based on an oximeter.
Yeah, I watched the
promo.
Yeah.
Yeah, and the thing that's cool is the patient can actually have access to all that information on their smartphone, and you at the office, you can log on to the circle that he has, and you can see and access the next day. You can check to see how he's doing without even talking to the patient. It's pretty interesting. Yeah.
It's and it really might be, and it's like $200, $250, right, for one?
Well, $299.
Yes, and then there was a discount, so I think about $270 US. And
then $14 a month gives you the access to the online.
$7 a month, Barry, gives you access to the data. Now you can either take that plan, or you can just buy the circles, and then after basically it's downloaded to the smartphone, the patient's smartphone, Or if you want to have access to immediate access, then you just pay, you register that circle, and it costs you $7 a month to continue to have access to that circle.
But going 7 days or 10 days and eliminating all the hassle that we always have looking at night-to-night variation, and knowing, seeing really what that patient's experiencing on a lot, and really what else do what's the biggest problem? The biggest problem, of course, is it doesn't include posture. So we lose that potential to pick up what could be really important in helping us go on in terms of treatment. But if the patient doesn't have supine oriented apnea, then it becomes less of an issue. So depending upon that initial diagnosis, this really has some, I thought some really good potential.
Well, when you compare the cost of a circle, say $270, as opposed to the cost of a Knox T3 is going to be anyway between 5,000 and 6,000 US. The Brabon is going to be the same thing for a full level 3, and the watch pads all over the place depending on which model. Yeah, but it's it's substantially more. This is so inexpensive. What I don't know, it'd be interesting to see durability, right? Because 270, I mean that's going to be interesting. I mean, we're assuming the thing will last. It's made out of stainless steel, he said, a brushed stainless steel. It's very attractive looking, but question is how durable will it be? So that remains to be seen.